Senior Professor at JLN Medical College, Ajmer. I welcome you all to this session on advanced pulmonary function testing. Today we are going to discuss diffusion capacity of the lungs, and our speaker today is Dr. Deepak Talwar. You know him very well. He is a well-known personality across the country. He is director and chair of Metro Center for Respiratory Diseases. For last 22 years, he is a postgraduate teacher, and almost 42 postgraduate students have been enrolled under him for DNB courses. He has got more than 82 research papers to his credit. He is DM in pulmonary medicine. So this is what you all know about him. We are listening this repeatedly about him, and I must say that he has got a passion for teaching. We have already had a splendid session with him on Body Box a week ago. Whenever I listen to him, I can recall a Japanese proverb which exactly fits for him. That is, better than 1,000 days of diligent study is one day with a great teacher. So this is how I can express my words for Dr. Deepak. I must also mention another quotation by Albert Einstein, that it is the supreme art of teacher to awaken joy and creative expression and knowledge. So without taking any much more time, I request Dr. Deepak to take up the session on diffusing capacity of the lungs. Dr. Deepak, please.
Thank you, Neeraj. These are the wonderful words. I don't deserve them, and you have praised me so much. Thank you very much. But I'm happy that I'm on this platform and going to discuss another difficult topic after body box plethysmography, and that is the diffusion study. And as we are moving to more and more advanced lung function tests, the idea is how to incorporate in the clinical practice, how to interpret them, and how to make some useful decisions out of the results of this test, which would translate into a better medical practice in the field of pulmonology for all of us. So today I'm going to talk about diffusion study, and as usual, there are going to be about 21 questions with multiple choices. We encourage all of you to participate with whatever knowledge you have on that question. And then we are going to, between Neeraj and me, are going to dwell upon it that, there may be many right answers, that's true, but still we will be coming to you with the idea that what is perhaps the most suitable or appropriate, or sometimes even more than one in those situations. What do we do about it? And how to go about it in clinical practice when we get these kind of results. Many a times we get these tests done with not a very accurate knowledge as to how to approach them, how to interpret them, and very important on methodology aspects of it. Because if a test has not been performed with a good methodology and acceptability, then perhaps the entire task of taking this procedure for an individual patient may not yield the results which we are looking for. So this is series 2, and we are going to focus on diffusion studies. And it starts with the question, and this is basically to see what do you think about the diffusion studies, and over to you, Neeraj.
Yeah, the question is, what do you determine in diffusion study? It is diffusion across alveolar membrane, or it is diffusion across alveolar capillary membrane, or it is diffusion across alveolar capillary erythrocyte membrane, or it is diffusion across alveolar capillary erythrocyte hemoglobin oxygen. Please put up your answer, poll.
Although the question looks little tricky, but it's very simple, and it depends upon what you are talking about when you talk about diffusion study. So I think that's the way we open this. And Neeraj has given you so many choices actually. And if you look at it, I think they are progressively becoming worse and worse. I do not know, Neeraj, how many diffusion studies are there across the 400 medical colleges, which last time Dr. Radha spoke about. And she said that there are 60 body boxes in 400 medical colleges, out of which, in fact, almost half of them are in the physiology departments and only half of them are in the pulmonology department.
Yes, that's true. And even after having these machines, they are not being used at its full capacity. So we have received answers. Number one, choice number one, 13, almost 14%, but maximum they have polled for choice number two, diffusion across alveolar capillary membrane.
Right. So I think the first point is got the, it just clinched the point on the basis of which we had made this question. So you can see, Neeraj, this is what we all think about. We are going to talk about alveolo-capillary membrane, and that's it. That's what the diffusion study is. Actually, diffusion study is a misnomer, and the exact name should be a transfer test. And there is a difference between what the US calls it, which is a diffusion study or a diffusion stat, versus the European countries which call it as a transfer test. That they equate them equally, because obviously the entire process and the whole units and everything remains the same. But why two names is because it is trying to reflect on exactly what are we trying to measure in this. Of course, it is a test which is trying to look into how can you exchange the gas which is there in the alveolus with oxygen, and it is able to permeate through the alveolar membrane, through the interstitium, through the capillary membrane, which is the endothelium, then through the plasma, and finally it enters into the RBC, crosses the RBC membrane, and then there is a hemoglobin here, and it gets attached to this hemoglobin. So what we do in a diffusion study is not simple, this diffusion, what we are talking about from air to aqueous phase, but it is more than that, that it is from air into the aqueous phase, and the aqueous phase has got a component which is in the plasma, which is in the blood, and as well as in the membrane of the RBC, which again is there. So there is another membrane which is there, which is erythrocyte, and finally when it crosses and oxygen diffuses into the RBC, it has to combine with the hemoglobin. So everything in this across the passage is going to be tested when we do a diffusion study, and that's why a better terminology is a transfer test rather than a diffusion study. And if you can see, it has got two components. One is this membrane component, which is alveolo-capillary membrane, which everybody had opted out. That DLCO test is actually looking at alveolo-capillary barrier or alveolo-capillary membrane, but that's only one component of it. Equally important is the second component, which is the blood, plasma, RBC, blood cell membrane. So this is another membrane here, but this is a blood component. This is predominantly determined on circulation. It is dependent on RBCs, and it is also dependent on the hemoglobin. So there are other factors which are important for this second part, which is going to be tested in this bundle test, which is called a diffusion study. So I think I hope I have made this very clear, that what we are testing here is not only a membrane, we are testing everything. And that is very important, because when we actually start the interpretation, if the test comes abnormal, it is not the membrane which is only abnormal. There could be abnormalities in the RBCs, in the hemoglobin, in the circulation. Everything is equally important in the interpretation, and they are, since coming in different parts, you can actually divide the components and then see to it which component is getting affected more. So actually the DLCO is reduced because of what? Is it because of the membrane, or is it because of something related to circulation or hemoglobin or other kinetics of the RBC and hemoglobin there? So what I'm trying to say here is, this is a broad test which is trying to look into many things, just not diffusion across the alveolo-capillary membrane. So that brings us to the second question, and I hand over it to Dr. Neeraj.
So the second question is, what is the unit used to express diffusion capacity? Is it milliliter? Is it milliliter per minute? Is it milliliter per minute per millimeter of mercury, or milliliter per minute per millimeter of mercury at STBD?
So STBD is a standard temperature, barometric and dry conditions. So this is a standardization which we are talking about. But I think again, the question is trying to tell you that what are you looking at and what are its units actually. So that again brings us closer to the concept of what we are testing in the diffusion study. So that's why I think this question has come up, and it is again trying to see, you know, our normal notion that what we do with the diffusion study. So basically we are in the first 3-4 questions, we are discussing what we think about it, and then we'll move on to the final details of the diffusion study, or what as I said is better to call transfer test.
So I will request audience to put your answers, please. So this is what we are discussing is ATS. It is described by ATS, these unit. While ERS, they use standard SI.
Yes.
I don't think there are
Yeah,
no.
Yeah, so the machines which generally we use, so we have to see our machines and see that what units it is giving in. Since the machines in India are actually tuned to this units, which are the ATS guidelines, it gives us in the milliliter, because it is the transfer factor is given basically in the ml plus or whatever it is. So let's see what people think about it.
So we haven't received any responses for this question as yet.
Or maybe there is some something in the support. Sometimes there is an issue at the support level related.
It is all showing 0.000%.
Okay.
When we discuss this question, this answer of this question,
I think so. There may be some issue in the support system. We'll go ahead. And obviously, this question also has become progressively more difficult. Can you see the answers have become slowly going on? And I was expecting people would choose either B or C out here. And this is what we are talking about. As I told you, you know, we are trying to look at measuring the gas exchange, which is occurring at the level of the lungs. And it's the volume. So volume has to be in milliliters of this diffusion limited gas. It's very important. You can't use any gas. It has to be a gas which is diffusion limited, so that if there is anything which is going to change, it is going to change through this diffusion process only. There are no residual changes, or there is no back pressure changes coming because of that. And this diffuses through the membrane each minute for a partial pressure difference of 1 millimeter of mercury. So what it means is it will be volume, that is ml. It will be diffusing across the membrane each minute. So it will be slash per minute. And it will be across some difference in the pressure, which is 1 mmHg. So it will be slash mmHg. And since all of them had to be standardized at the level of ambient temperature, pressure, barometric pressure, as well as humidity, so dry. So STBP is the standard derivation on which these are converted into to give, so that you have a comparison value for all your tests wherever you are, whether you are 10,000 feet above sea level, or you are in an area where there is a 50% humidity versus somewhere where it is 10% humidity. So it is primarily standardized to the conditions which we are talking about, standard condition, not the one which is in your lab basically. So they need to be standardized to that. So it is millimeter per minute per millimeter of mercury at the standard conditions. So that brings us to the question 3. So support, is there any issue about going for a question, or we discuss answer among ourselves?
You can discuss, sir.
No, sir, you can discuss.
54% actually polled for option 4 in last questions. Question
okay, so that means we had almost 54% people who were correct. So although we do not know much about the diffusion capacity, but we have seen the reports coming up as this. So I'm very happy that 50% know that the unit is milliliter per minute per mm of Hg at a standard. The only thing is that it needs to be standardized, because when you do it in Mumbai, you do it in Delhi, or you do it in Ladakh or Srinagar, then it has to be in a standard condition. The values cannot change just because either the altitude is high, or the temperature is different, or there is a humidity level which is different. So it has to be standardized. That brings us to question number 3, and I move over to Dr. Neeraj.
So it's like a pre-test, and we'll definitely have a post-test also after Dr. Deepak's talk. So question number 3 is what are the factors influencing diffusing capacity? It is the area of alveolar membrane, is the thickness of alveolar membrane, or driving air pressure, or driving vascular pressure, or all of the above.
I think this we have in the opening slide itself discussed. So people who joined right from the beginning would guess the correctly because it has been amply described. And again, the important point in this is to see that if it is dependent on one factor, it is very easy to interpret the results. But once it is dependent on many factors or other factors also, then obviously the interpretation needs to consider this, that a low value or a high value does not mean simply one particular item. It may be many other things, and you need to actually look into the details of each and every component of it.
So those who have logged in from right from the first minute of this talk, they have answered very correctly. 79% responded for E. Option E, 79%.
So I think people have been logged in and they are right from the beginning interested in learning from diffusion study very correctly. I told you it is about the membrane and the air which comes onto the other side of the membrane and the blood which comes onto the other side of the membrane. So there has to be a vascular pressure, there has to be a air pressure, and there has to be a membrane copulate. So all of them are equally important. The membrane, it is important to see its area and thickness. That is very true. And most of the time, actually, we are bothered about the area and the thickness of the alveolar membrane. We forget about it is the ventilation part equally important because the air must reach the alveolus. And also, the blood supply must come from the pulmonary circulation to reach the pulmonary vasculature. So hence everything becomes important when we talk about the diffusion capacity. So area of the determinants of the diffusion capacity. So this is important for a clinical application. So if you look at the diffusion capacity low, it could be that the area of the alveolar capillary membrane is abnormal. It is thickness of the alveolar capillary membrane is abnormal. The driving pressure which is created for the oxygen to go across the membrane may be different. It may be the flow in the pulmonary vasculature which may be obstructed, or it may be like increased pressures in pulmonary hypertension. All these will ultimately affect the diffusion capacity. Area of the RBC membranes, how many RBCs are there? That is also very important. And finally, it is ultimately dependent upon a hemoglobin. A simple low hemoglobin can alter your diffusion capacity when everything else is normal, and you keep scratching your head that why the diffusion capacity has come down to be normal, because it's not a standard practice in the laboratories to do a hemoglobin test prior to doing the diffusion study. And it may be like if the diffusion study actually would presume it to be somewhere around 13.5 to 14. And if patient has got 8 grams of hemoglobin, you can imagine the diffusion capacity is going to be around 55 to 60%. And if you see that report, unless and until you correct it, you will think, oh God, this is the patient who's got a severely impaired diffusion capacity, and start working for what are the reasons for decrease in the diffusion capacity. So it is basically a transfer factor, as I said in the beginning, of oxygen from air to oxygen onto the hemoglobin in the RBCs. So the entire process is being tested in this diffusion capacity. So what is a diffusion capacity? To a pulmonologist, it is a window to pulmonary microcirculation. So there could be structural factors like lung volume, on which it is highly dependent, thickness and area of the alveolo-capillary membrane, volume of hemoglobin in the capillaries, which are supplying this ventilated alveoli, and it is also dependent on functional factors like what is the ventilation perfusion mismatch or match in the lungs. It is dependent upon the composition of the alveolar gas. It also depends upon the diffusion characteristics of the membrane, and it is also dependent on the concentration and binding properties of hemoglobin, which is there in the pulmonary vasculature or the alveolar capillaries. And finally, we are going to test it with carbon monoxide. So it ultimately will depend upon the equilibrium kinetics which are made between the carbon monoxide and oxygen tensions between the air and the blood in the alveolar capillaries. So this is the entire process of the diffusion capacity, and I'm pretty sure that this list of what the window is showing you about diffusion capacity is trying to tell us how complex the process is being tested by a simple test like testing what is called the diffusion study. So that brings us to question number 4, that what are the components of DLCO which we measure in our labs? Over to you, Neeraj.
Yeah. What are the components of DLCO test? 1/DM. What is DM is membrane conductivity. 1/theta, that is carbon monoxide hemoglobin chemical reaction rate. 1/QC, that is capillary blood volume, or all of the above.
So I think the prelude to the diffusion study which we are going to discuss has been enough to emphasize that what all is important. So I think this answer will also come near to correct for us.
100%.
I'm eager to hear from Neeraj.
100% correct.
So I think we have finally been able to we have been able to drive in the correct thing what we wanted right at the beginning, that people should understand you are not just testing one thing, you are testing many things, and the most important things are these 3 components which you have picked up, that membrane component, then this chemical reaction reactants of the gas which we are using, and obviously the capillary volume. So then this becomes now easy that how to go about it. So these are the 2 major factors to be considered, and they come in the report itself. The membrane conductance, that is the DM, and carbon monoxide and hemoglobin reaction, that is theta. And then it is dependent upon the vascular supply or the vascular blood flow. So it is the uptake of carbon monoxide by hemoglobin, which is determined not only by the reaction rate between the carbon monoxide and the blood, but also on the pulmonary capillary blood volume. And what is important here? The important is that we think diffusion capacity or the diffusion test is the membrane test. In fact, 80% it is dependent upon the theta QC. Only 20% is contributed by the 1/the DM component, which all the time pulmonologists think about. We are thinking about emphysema, and we are thinking about interstitial lung diseases. We are thinking about this alveolo-capillary membrane. We are talking about the membrane. The membrane component is only 20%. So then we will see what are the fallacies where even if there is a disease, we may not be able to pick up only by a single test, and you need to incorporate a lot of other things into your information, rather into your information basket before you make a final diagnosis also. And very importantly, this diffusion capacity which is done, it is primarily being reported on 2 major factors. One is the ventilatory lung function, that is the volume of the air which has come from the each breath from the air into the alveolar units. So that volume of the air is also very important. So if the patient is severely obstructed, then obviously the volume is going to be less. And also very importantly, as I told you in the beginning, hemoglobin. So it presumes that the ventilatory lung function and hemoglobin are normal. Unless and until you correct it for these things, you will not be able to get the corrected value of the diffusion capacity. So that brings us to question 5, and we move on to Neeraj.
Now, what is the method of DLCO test? That is DLCO single breath diffusion, DLCO rebreathing test, DLCO intra-breath test, DLCO SB at 2 different PO2 values, or all of the above.
So this is primarily to this, there's no answer to it. The only question is, I think whatever you have seen or whatever you have used or whatever you have read about, you will be knowing about that. And obviously there are lots of centers which would be doing only one type of a test, because it's not easy to have these kind of tests available and to able to make them run efficiently because of not only the cost of it, but also the consumables like gases and other things which are required to run these kind of tests. So we used to have this rebreathing test, which used to collect liters and liters of the expired gas for estimation, which was very, very cumbersome. We required a big space to have these kind of machines, but we are lucky that we don't have to use these kind of machines now, because in clinical application, we are obviously using the simpler machines.
So 100% they have polled for option E, all of the above.
All of the above. So very correct. All of them are correct, but most of the times and most of the centers will be doing a single breath test. So just a quick look onto it that, what are these various types of tests available, and especially now these days they are available for clinical use almost by the companies, and they are providing almost, various companies are providing different type of diffusion tests. So I think what is important for us to understand is which one to invest to. Now, single breath hold technique is the simplest, fastest and highly standardized technique, and it is easy to calculate. And since it is using carbon monoxide, which is normally not present unless and until patient is a current heavy smoker, there is no back pressure here. But it is disadvantage because it is a single breath hold. So obviously the time is limited, and the time given for the gas to reach the alveolus and intermixing will require a good VQ match. So in patients who have got poor VQ mismatching, it is not a sensitive test and it may not give you an accurate value. And very importantly, because it requires a breath hold, single breath hold test. It's not a physiological test. Suppose if I'm doing an exercise test and I want to see whether my exercise, what happens to my diffusion capacity, I won't be able to do because it requires a single breath hold test. And of course, this is the most widely clinically used test, and it is also used for screening purposes and most of the research purposes. The rebreathing technique is because it is less affected by changes in the alveolar volume, and it is also less sensitive to ventilation perfusion abnormalities because you keep rebreathing it till the time equilibrium comes. So obviously, if there is a lot of VQ mismatch, it will be able to take care of by the rebreathing technique. But it requires complicated calculations, sophisticated analyzers, and in such situation, because of rebreathing, carboxyhemoglobin can produce a back pressure, which will lead to abnormally changed values of the diffusion study test which you perform. It is also used clinically, and it is considered as the most accurate test for the diffusion measurements. So it's most accurate also for one reason, because breath hold requires about 10 seconds, and there are people who are very sick and won't be able to hold their breath for 10 seconds. So you can't perform a single breath hold test. We will also see some limitations which are not there in the rebreathing technique. In fact, sick patients can do this kind of a test much better. Those patients who have got small vital capacities can again do this test much better. And people who can't hold the breath for longer, they have a tachypnea, they have a rapid respiratory rates, will be able to perform this test. But then, as I said, this is a complicated test. It requires a lot of technical expertise as well as gases and analyzers, and it is more expensive, so it is no longer used in clinical practice in most of the centers for their daily routine use. Other is intra-breath. So during the single breath, in the breath part itself, you check it because you are not holding the breath. So patient is breathing normally, and during the breath, you do the measurement. That's why it's called intra-breath diffusion capacity test. There's no breath holding required. It also has a complex calculations. It is not standardized well at the moment. VQ changes do affect the results here also. It is in clinical use, but then only when the patients cannot hold their breath or you want to do it during exercise. So it's a physiological test because it is during normal breathing you perform the test, but it's not standardized. I think the biggest disadvantage is it's not yet standardized. However, if you order the body box and the diffusion studies test along with it, there may be a component of intra-breath test also included in it, where you can do single breath. You can also do intra-breath depending upon your patient's condition. So if your patient condition is not good, you can go ahead and do an intra-breath test. But these test results cannot be compared to the single breath test results. So obviously, the same test results over a period of time need to be compared as well as interpreted on the vis-a-vis change which is happening there. Most commonly clinically used is a single breath hold test. That brings us to the question number 6, and I move on to Dr. Neeraj.
So DLCO test uses all the gases except, there are 4 options: helium, methane, neon, and argon. We know that these gases should be relatively insoluble, chemically and biologically inert. It should be used for DLCO estimation.
So that there is no previously present in the body where it can actually change the compositions.
100% they have opted for B. is very surprising.
Argon?
No, B, methane, methane.
Methane, B. Okay, there is a test which can be done with methane also, but generally methane is not used. It is helium we are using actually. So what, as I think Dr. Neeraj has very rightly said, you know, you need to be insoluble. The gas needs to be chemically and biologically inert. All of them are there. All of them. You can use helium, methane, and neon. But most commonly used gas in India is actually the helium only. But some centers in Europe are using methane also. And it also takes carbon monoxide, which is 0.3% in concentration, and rest is oxygen and nitrogen. So the gas which is used for a diffusion study has a fixed mixture of a tracer gas, of carbon monoxide, of oxygen and nitrogen. So we know oxygen will be 20%. We know that carbon monoxide is going to be 0.3%. Tracer gas won't make much of a difference, which is going to be helium. Rest all is going to be nitrogen there. So we know this is a composition. It is a standard gas composition. What's the idea why I brought this question is that you must remember, for doing a diffusion study, you need to have a standardized gas which has a specific composition to be used with the machine. So that's a big catch. You can't ask an industrial gas people to provide you with a mixture and you can use it. It doesn't happen that way. So you need to have a predefined, preformed mixture of these gases, and they are expensive. So that is why whatever is the cost of the diffusion study, which is a recurring cost, it is the cost of the cylinders of these gases, which are in fixed composition. And that is how the analysis is going to be done. If the composition varies of the inspired gas and it is not accurate, the diffusion study is not going to be correct. So helium definitely meets most of the criteria, but its diffusivity is considered to be higher than that of carbon monoxide. We are using two things here, carbon monoxide as well as helium. Helium is primarily for the volume, and carbon monoxide is for the transfer from the air into the blood. So basically we are going to look into both the components, the volume as well as the membrane component. So that's why two gases compositions need to be analyzed, and we use helium as well as carbon monoxide. And as I told you, carbon monoxide is the one which we standardly used, but methane instead of helium can also be used. FiO2 is like 21%, which I already said. So that brings us to, why we have a carbon monoxide 0.3% here. Because the measurement of oxygen diffusion capacity requires alveolar oxygen, oxygen in the pulmonary capillary blood, as well as the rate of oxygen uptake by the blood. Now, whatever is the rate of carbon monoxide, that is what is going to determine the rate. So basically they're parallel. So that is why carbon monoxide is used, because hemoglobin will combine with carbon monoxide very, very quickly. This is almost 230 times more. And it is so rapidly that the pressure never builds up. There is no back pressure of carboxyhemoglobin there in the capillary blood flow. And also there is a very low solubility of carbon monoxide in the pulmonary membranes. So it doesn't stay there. Whatever is there in the air, it goes through the membrane, doesn't stick into the membrane, goes straight into the blood, doesn't stay into the blood, goes straight into the hemoglobin and gets attached to it. And which you can easily check, and then you'll be able to do the equation analysis for calculation of the diffusion capacity. That's why we need carbon monoxide. But of course, there is a caveat here, and that caveat is a smoker. Current smoker who has smoked 5 cigarettes or 2 cigarettes or 3 cigarettes prior to coming for a diffusion test in the last half an hour is definitely going to upset this entire equation, because we consider that most of the people will not be having any significant carboxyhemoglobin in their blood. And that's the assumption on which the DLCO test is being done. So if not, then the correction factor of carboxyhemoglobin needs to be added to this diffusion test study formula. Equipment is obviously, because you need to do a spirometry along with it. So there is a spirometer and there are analyzers, and we will require 2 analyzers, helium and carbon monoxide. So it's basically 2 analyzers, and then you have a cylinder which provides you a fixed gas, which generally contains about 10% of helium, 21% of oxygen, 0.3% of carbon monoxide, and whatever is left behind is compensated by the nitrogen. And this mixture you inhale, you hold the breath, and then you exhale. So there is a sampling valve, chamber where you exhale out, and from there it will be analyzed. So you will have the composition of the gas which you inhaled and the composition of the gas which you have exhaled, and from there you will be able to estimate how much did it cross and what is the transfer test. So it will not be just a diffusion capacity, it will be the complete transfer test of estimating oxygen in the air which you have inhaled into the alveolus to finally addition of it to the hemoglobin in the RBCs. And that brings us to question 7. Over to you, Neeraj.
Yeah, DLCO test requires following steps: breath hold, forced inspiratory maneuver, forced expiratory maneuver, all of the above. Those who are performing this test, they won't have any problem in answering this question.
Yeah, I think Neeraj has given a very good hint that if you do the test, you will know that what are do's and don'ts for the diffusion study, because each and every procedure of this this spirometry procedure which you do during this test is going to actually be the determinant factor for the diffusion study test results. So that's why it is very important that the performance procedure or the person who's performing the test knows actually what are the fallacies and should not fall into that.
So 82% they have polled for option D.
So not unusual. I had expected this, and that is why I had put this all of the above. I should have put in even none of the above, one of the options. I would have been happier that way. Now this is what the entire process is. You can see that on this side, you can see that the person inhales from the residual volume. So once the person is already tidal volume breathing, he exhales out to the residual volume, and then he takes a breath in which that gas will get into the lungs as quickly as possible. That's true, but I'll tell you, it doesn't need to be a forced inspiratory procedure. It's like slowly filling. Otherwise, you'll have a back pressure or increased pressure, which will collapse the alveoli. So I'll tell about this little later. Then you fill in the lungs completely, reach the total lung capacity, let the gas equilibrate, and then that's called the breathing breath hold time, which is about 10 seconds. And then you exhale out. Initial part is coming from the dead space, which is thrown out, and the later part, which is actually the gases which is coming from the alveoli, which have actually gone into the process of diffusion between the air and the blood, is the one which is collected into the bag, and their concentrations are calculated. So this is the entire process which you go through, which is from exhalation to RV, from RV to inhalation to TLC, breath hold, and finally the exhalation till you are able to get and collect the gas. Now you remember that the gas, the sample, there is a bag, sample bag. The sample bag needs to have about 800 ml to 1 liter of it. So if you are not having that much of capacity, that will tell you why the diffusion capacity test will be inadequate, because the patient doesn't have that much of the volume. So if that volume is not there, the diffusion test will not be accurate at all. So those patients who have got very low vital capacity will not be able to perform the test adequately. They may do the test, but then the reports are not going to be fallacious. Now, I was coming to, what you need to do. Breath hold is correct. Everybody was right that you need to do breath hold. But exhalation is non-forced. And this is what we are going to discuss, because if you put on a force during exhalation, then obviously the blood volume is going to come into the lungs, the airway pressures are going to increase, and it is going to become non-physiological. And non-physiological measurement will change the DLCO value which we are going to collect. So first thing is, you can see from here, the first step is that the person is tidal volume breathing, and then they do a non-forced exhalation till the time they reach the residual volume. And then the valve opens and you inhale the gas. And this gas inhalation, again, it's quick, but then it is slow and smooth. So it's not like forced inspiration. You don't do forced inspiration into this. And you reach the total lung capacity. Obviously, you need to do it fast. So it means that you need to quickly inhale and not do it with a force. So quick inhalation and a forced inhalation are different. So that is why what we are trying to tell you, we don't want to create unnecessary, unphysiological pressures into the chest which will alter the diffusion capacity by compressing the air which is inside, as well as increasing the intrathoracic pressures will decrease the pulmonary blood flow and again change the diffusion capacity. Once you reach the total lung capacity, which you have filled in the complete lungs, you hold the breath, that is the step 3, for 10 seconds, and then you exhale out. This is again a quick and unforced exhalation. You don't force it too quickly. You're supposed to do it in less than 4 seconds, initial part being discarded, and then you can see that after the discarding of the initial part, you sample the after that. So initially about 800 ml you throw out, and then you collect the rest of the gas. Now the kinetics will tell you this is the time when the kinetics of whether you use methane or you use helium and carbon monoxide, they become almost equal. So I think people were talking about methane. Methane is also used, but we are using helium because it is also bundled together with lung volume. So helium is used for lung volume studies also. So that is why one gas can be used basically for both the purposes. So what can wrong happen? So this was very important, because if the procedure is not done properly of the diffusion study, like spirometry and lung volumes, the values will be fallacious. So if you slowly inhale, then that is also wrong, because there will be a lot of time wasted in that, and in that time the equilibrium has already started in. Then there can be a transient overshoot, or there can be a stepwise inhalation where you stop it and then start it, and then these are all which is going to affect the kinetics of carbon monoxide as well as helium. If you are not able to sustain this complete breath hold, that is also going to affect the diffusion of the gases across the membrane. And also there can be, if there is a leak from the side, then when you are exhaling out, then again there will be a possibility that you are not able to get the exact gas for sampling which is required. So what we want is no Valsalva maneuver, no Muller's maneuver. So forced exhalation is Valsalva, and forced inhalation is a Muller's maneuver. So for both inhalation as well as exhalation, during the process of a diffusion study, we don't want forced procedures, because one will decrease and another will increase the diffusion capacity. So as we know, we have a criteria of acceptability for spirometry, for lung volumes, we did by body box. We also have acceptability criteria for the diffusion study. Diffusion study between same patient at different points of time or at different levels of testing or different attempts to test would differ. So if the inspired volume should reach within 85% of the largest vital capacity, so that you should be able to get enough gas into the lungs, and it should be obtained within 4 seconds. And then you should be able to hold the breath for 10 plus minus 2 seconds. That means 8 to 12 seconds. There should be no leaks, no Valsalva, no Muller's maneuver during the breath holds, and 2 such acceptable tests with test interval time of 4 minutes. So, you need to allow some time for whatever the gases have gone into the blood vasculature should be able to get washed off. So if you have performed one test, you need to rest about 5 minutes before you perform the test again, so that the residual gases into the blood have got washed out. So also there is a repeatability criteria that when you do 2 tests, they should be within 2 ml value of carbon monoxide per minute, milliliter per minute per millimeter of mercury, or within the 10% of the highest values. So again, this is subjected to acceptability as well as repeatability criteria for the diffusion study to be adequate and worth reporting, and also because it is used for monitoring. So when you need to change the 2 values between the test done 3 months ago and the test done today, the acceptability and repeatability criteria on 3 months ago test as well as now must be maintained. So if you do it at different laboratories which follow different kind of procedures or perhaps different kind of acceptability criteria or repeatability criteria, then they may not be the same. So it is a possibility that if a diffusion test has been performed in another machine by another operator in a couple of months ago, and what you do now, it may not be comparable at all. So it's very important to remember this, that this test needs to be standardized for its acceptability as well as repeatability criteria. I'm emphasizing this much more because most of the times we'll see the diffusion study done at lab A versus diffusion study done at lab B. Remember that 10% to 15% variability can be because of that also. So unless and until you have done it at your own lab, it will be very difficult to take a therapeutic decision dependent on this particular threshold of 15% change in diffusion capacity means you need to alter the management and the patient is either doing not good or perhaps has deteriorated. So precautions which are required while performing the diffusion test is that not more than 5 tests, because otherwise there will be a back pressure of carboxyhemoglobin into the blood and then the values will be fallacious. At least 4 to 5 minutes allowed between 2 tests. Subject must be asked to refrain from smoking or any other carbon monoxide exposure prior to coming for the test, and this is required for 24 hours. I understand it is really difficult for smokers to withhold their smoking for that long. So generally, if they have not smoked for last 6 hours or 4 to 6 hours, that is generally we accept in our laboratory. For patients, but if we find anything wrong, then obviously we'll try to rectify it by correcting with the carboxyhemoglobin level. So you have this CO monitors. So you do a breath analysis of CO, and if you find it acceptable, go ahead and do the test. If you don't find it acceptable, you can still perform the test, but then the diffusion capacity which you have calculated in that patient with had a higher HB levels needs to be corrected for that value. For patients having obstructive lung diseases, even up to 12 seconds of the time may not be sufficient. And in such people, when we start with the exhalation, the inhomogeneity in ventilation is so much that yet the gases have not been able to diffuse across the into the ventilatory system or into the lungs properly, that you may underestimate the diffusion capacity. Inhalation of the test gas should be maximal. And of course, during the breath hold, we don't want any kind of very forced maneuvers to be happening, trying to breath hold at that point of the time. So it should be a quiet procedure at that point of time. That brings us to question number 8, and over to you, Neeraj.
Yeah. So next question is, DLCO needs adjustment for all of the following except age, hemoglobin, lung volume, carbon monoxide hemoglobin, and all of the above.
I think we have made enough prelude by the previous, slides and talking about it that I think we will get correct answer here. We have discussed this many times.
So there are much variation in the answers. 41% they have polled for option E.
All of the above.
Yeah.
So they are these 50% people are those who are right from the beginning.
33, 1/3 they have opted for option A, age. Now,
So
17% for option D, carbon monoxide.
So that was preceding slide. So I'm pretty sure that those who did not consider hemoglobin and lung volume has joined late, because in the initial itself we started saying that the important aspect of the 2 important determinants of diffusion capacity are hemoglobin and the lung volume. So it will presume that the lung volume is good, acceptable, and hemoglobin is also that 13.5 to 14 which is taken between females and males. So if that is not there, you need to correct it. Otherwise your values are all going to be of no use. We have to have a predicted values on which the age, the sex, the height and weight, everything will be included into it. That is true. The demographics will be important, but more than our demographics, because we know the values are like 25 ml per minute per millimeter of mercury, or up to 30 or 35, 32. That's the maximum values we get. And if it is less than 20, you know that it is abnormal. So even the absolute values will give you a hint, but obviously you need to have percentage, which is very important, and percentage will be dependent on demographics. That's right. But then besides this demographics, very important is hemoglobin and lung volume, and carboxyhemoglobin if the patient is a smoker. Carboxyhemoglobin only if the patient is a smoker, like I told you in the previous one, that this is going to affect because carbon monoxide is the gas which is trying to go across the membrane, and it is supposed to be equilibrating so fast and so easily that we are trying to calculate and depend our equation on that. So there are lots of adjustments which may be required, because considering that the diffusion capacity, so-called as transfer test, those who have joined late, I would like to emphasize diffusion study is not an appropriate term, because you are not just looking at diffusion across the membrane, it's a transfer test. So it dependent upon age, gender, height and race. It is dependent on hemoglobin. For every drop in 1 gram of hemoglobin, the diffusion capacity will decrease by 7%. It is also dependent upon lung volume, that is alveolar volume, because whatever gas we have used for testing, it is going to be dissolved into the available volume of the air in the lungs, and that is available. So if there is trapped, it will not be included into it, because that will not be able to equilibrate what we have inhaled. So it is only that gas which is actually in direct connection with the air, with the mouth, is the one which is going to get into the dilution with the gas which we are inhaling. So alveolar volume is important. Carboxyhemoglobin, every 1% increase in carboxyhemoglobin will lead to fall in 1% of diffusion capacity. So if patient has come after taking 2-3 cigarettes in the last half an hour, carboxyhemoglobin will increase up to 4 to 5%, which is going to decrease 5% diffusion capacity, and it may give rise to a abnormally low diffusion capacity. Otherwise, it may be not a factor at all and to be considered in that individual. It also depends upon PI too, altitude. So that's why I was telling you right in the beginning that if you perform the test at Ladakh, or we do it in Srinagar, and we do it in Trivandrum, or we do it in Kochi, the sea level versus the high altitude level, the PiO2 is also a determinant factor which needs to be considered for interpretation of the diffusion study results. Alveolar carbon dioxide is also very important. Some of the patients of COPD who have already retained carbon dioxide, it increases their diffusion capacity by displacing the oxygen from there. So similarly, if you do it at high altitude where there is less oxygen, again the diffusion capacity will be higher. Exercise also changes the diffusion capacity. So we tell the patients not to exercise prior to coming to us. And in case they are going for a cardiopulmonary exercise test, that will be performed after the diffusion study. Similarly, if you are doing a 6-minute walk test for these patients, preferably that is also posted after the diffusion study is done. And of course, the body position in which it is done. But because we do it in a sitting position, so there is not an issue as far as body position is concerned. So DLCO is the diffusion capacity or the transfer factor. It is also called TLCO. DLCO, TLCO is the same thing, and it is equal to KCO into volume, alveolar volume. VA is the alveolar volume. So these are the two factors which are to be considered, and KCO is the rate of uptake by the blood of the gases which we are testing, and VA is the area of lung which is available for the gas exchange, So which is not available is the one which is not in communication. So if you have a bulla, that will not be included into it. So what are the clinical situations where a diffusion study is helpful? So diffusion study we know is a specific thing, but now we have learned that it is an insensitive predictor of just an abnormal gas exchange, particularly during exercise. So it is very important that can a low diffusion capacity predict that it will cause exercise-induced desaturation in a patient? So if a diffusion capacity is less than 50%, that can predict that this patient will develop hypoxemia on exercise. However, the levels above 50% do not accurately predict exercise-induced hypoxia. So it needs to be almost 50% of the diffusion capacity needs to be gone before exercise-induced hypoxemia will be produced. And also, a normal diffusion capacity or DLCO does not rule out oxygen desaturation with exercise. So there are other factors for exercise desaturation also. So you can understand that the clinical situations in which we are using this test needs to be interpreted depending upon keeping these things in mind, that they are not so specific that you can be totally relying on that. But yes, there is a data which suggests that those people who have got low diffusion capacity, they walk less. So physical activity is less in them. And of course, there's a data that, in HIV cases, if you perform the diffusion studies like you do in amiodarone lung disease, in patients who are on cardarone or amiodarone, if you perform serial diffusion study tests in HIV or patients who are on amiodarone, you can pick up the diffusion abnormalities early, and early interstitial lung disease or early opportunistic infections in HIV can be diagnosed with that. So a low DLCO in a normal chest radiograph is completely compatible with the diagnosis of either an early interstitial lung disease or very important pulmonary hypertension. So if you find everything normal, the chest X-ray is the normal, the spirometry is the normal, the lung volumes are normal, only isolated diffusion capacity, and you do a chest X-ray and you don't find anything, there are two things: either the report is wrong, or there is something which is still possible, which is in this situation, which could explain this decrease in diffusion capacity. Keep two conditions in mind, that is the early interstitial lung disease, which will have normal chest X-ray, and also pulmonary hypertension, which also will have a normal chest X-ray, and rest everything like spirometry and lung volumes also normal. So remember that low TLCO, now I've used the same term again and again because I'm trying to tell you that TLCO, DLCO is the same. It is only the way we write it, transfer factor or a diffusion capacity, may be associated with high respiratory neural drive on exertion, which is a key correlate of exertional dyspnea. So patients who have a low DLCO will be less physically active. And this is one of the signs in COPD patients. You can see that, if they have less DLCO, they must be less physically active, because this is definitely going to be correlated with exertional dyspnea. And that will obviously limit the patient as to how much physical activity they can do. And that brings us to question number 9, and over to Neeraj.
So what are the indications for DLCO? You recommend DLCO in which conditions in practice? Interstitial lung disease, pulmonary hypertension, COPD, sarcoidosis, or all of the above? I think it is the easiest question.
Easiest question, but what we are trying to look at is that, when you do not have a diffusion capacity, you will be sending the patient for diffusion test to somewhere else. So you do it only in very specific conditions. If you have your own test available in your institute or in your clinic or in your lab, obviously you will be using it in almost all conditions, because you know that how much importance of this test has. And I'm sure this test gets more importance than the lung volumes. However, you will realize over the day today that after seeing the last body box, actually everything is to be integrated together to look at what is physiologically going on abnormal, how to therapeutically intervene, and how to see whether there is improvement or deterioration going on.
So 84% they have polled for all of the above.
Right.
13% for option C, that is COPD.
Oh, I thought it would be ILD. Actually, ILD is the condition most of the times when people would be thinking about. But COPD, I think looking at emphysema is something what people are talking about, that they would be interested in looking at the diffusion capacity. So first and the foremost, reason to perform the diffusion capacity in the clinical practice is when the patient comes with shortness of breath and you just do not know what is the cause of it. So you need to find out, even if the spirometry and the lung volumes are normal, whether the diffusion capacity is normal or not. So it is a sensitive indicator of finding out whether shortness of breath is because of lung or it is because of other causes of shortness of breath outside the lungs. So obstructive, restrictive, vascular diseases, wide spectrum of lung diseases will affect the diffusion capacity, and that is why it is a sensitive screening tool for patients who are complaining with shortness of breath on exertion. So it's a very important test which needs to be bundled whenever you are trying to look into any patient who comes with shortness of breath and you don't have a clinical diagnosis of COPD, asthma, interstitial lung disease, pulmonary vascular disease. You just want to know what is going on wrong. Why is this patient complaining of breathlessness? Even it could be anxiety actually. maybe no lung cause. It could be cardiac cause. It could be a chest wall causes. It could be causes in the blood, like related to hemoglobin. So anything can cause dyspnea, but broadly looking into lung as a cause of dyspnea, diffusion capacity becomes a screening tool for that. And it will be able to screen early ILD, early emphysema, pulmonary vascular disease, which is the most frequently missed diagnosis if you do not do the diffusion capacity. So if you have everything normal, only abnormal diffusion capacity, which is low, you start wondering that what is happening here, in which the lungs are not getting affected. It is primarily the vasculature which is getting affected. Occupational and drug-induced lung diseases. Very importantly, we do it for the follow-up, where we want to know whether the disease is progressing or there is a therapeutic good response, particularly in patients with ILD and sarcoidosis. And also, we use it for severity assessment. Whether it is COPD or ILD, diffusion severity correlates with the survival. Worse is the diffusion capacity, the poor is the survival. We have seen in ILD, we have seen in COPDs, we have seen in sarcoidosis, diffusion capacity is a very important determinant of survival. So that is why if you get a very poor diffusion capacity, like less than 30% or 25%, 25% is considered as very severe. So that shows a very poor survival, whatever may be the cause of the disease, be it COPD, ILD, or a pulmonary hypertension or sarcoidosis. The pathophysiology of decreased diffusion capacity in all these conditions are different. You can see that we are testing basically in the diffusion capacity, oxygen in the alveolus, which has gone, crossed the membranes into the blood, and from the blood plasma into the RBCs and onto the hemoglobin. So if hemoglobin is less, it will be anemia, which is causing decrease in diffusion capacity. However, if there is an expansion of the alveolar space, then this amount of air is going to be much more, and then the diffusion capacity is going to be less. Also, if the blood volume is less in the pulmonary circulation because of pulmonary hypertension or pulmonary thromboembolism, again there is going to be a decrease in diffusion capacity. If the alveoli are collapsed because of the pneumonia, atelectasis, or pulmonary fibrosis, again there is going to be a less diffusion capacity across the membrane. There is a membrane defect here. And finally, if you have removed a part of the lung which is available for the diffusion, the diffusion capacity is going to be less because the area of the diffusion has itself decreased because of pneumonectomy, lobectomy, or whatever is the surgical procedure done to remove the part of the lung. So there can be not one reason for the diffusion capacity to be impaired, but there could be so many of them. So now I think you will be able to understand that looking at one value of diffusion capacity, which shows that it is 50% of predicted normal, does not give you a hint as to what is going on wrong here. Is it because of low hemoglobin? It is because of the large gas volumes. Is it because of the low blood volumes? Is it because the membrane is abnormal? Or is it the entire part of the alveolo-capillary unit which is missing because of the surgical resections? So there are so many causes which needs to be interpreted, which requires a good history, which is to be available to the labs which are doing the test and going to report the tests. That brings us to question number 10, and over to Dr. Neeraj.
Yeah. Next question. Interpretation of diffusion test requires following parameters: DLCO, VA is alveolar volume, KCO, or all of the above.
No, I think this is also a very important aspect, which is a learning, which is a learning objective of this entire or the series or whatever is the workshop we are doing on diffusion study. That most of the time we are looking at the diffusion study, which is the DLCO. So is the DLCO only important? Are the other things not important? And if they are important, how can they be helpful in making you a right choice and a right decision in interpreting the diffusion study test results? So that is why I think this question has come in, and I am awaiting the answers.
100% they have polled for option D, all of the above.
I'm very happy that whether it is a learning over last couple of slides or whether you are doing it in practice or you are students who have learned this, I'm very happy your answer is correct, because alone diffusion capacity, by now we have made it very clear, does not mean anything. You need to know which component. Is it VA component or is it the KCO component? So there are these two different components by which you can now, you have seen previously, In some of them, it is the VA component. In some of them, it is the KCO component. So this becomes very important to know that the changes in the diffusion capacity have primarily come because of the VA component or the KCO component. This is what we are going to dwell upon, that the transfer coefficient of lung for carbon monoxide is KCO and alveolar volume is VA. Generally, we think that it is like DLCO or TLCO divided by VA becomes the KCO because it is a volume dependent. And when you correct it with the volume, it becomes the independent of the volume. So we bring the question number 11, and for this, I hand over to Dr. Neeraj.
So another aspect, DLCO may be increased in certain situations. So what are these conditions? What may be these conditions? Pulmonary hemorrhage, bronchial asthma, Valsalva manure, obesity, or high altitude.
So this is a negative question. So, you know, out of these, only one is there, which is not increasing the DLCO. I think Dr. Neeraj said that this is turning around. All the time we are thinking about low diffusion capacity, but here we are talking about increased diffusion capacity. That can also help you to get into some clinical situations. What are those? So all of them are there except one of them. So it's a negative question. You need to choose one which does not increase the diffusion capacity.
So the responses are very surprising. 50% opted for bronchial asthma and 50% for high altitude.
Okay, so I think again, what we need to understand is that everybody has accepted, I think, the pulmonary hemorrhage because RBCs are there. So they are going to take that, and that is why it is going to cause increase. So everybody knows that pulmonary hemorrhage increases the diffusion capacity. Obesity increases the diffusion capacity because of the reasons which we are going to discuss in the subsequent slides. High altitude, we discussed about it, but I think I mistook it for PiO2 because PiO2 is the one, and once you correct it, then it will not be a increased DLCO. It will be, once you correct it for the altitude, it will become normal only. So anyways, as I told you that high DLCO could be either because there is more blood in the alveolo-capillary area, or it could be just miscellaneous like various other causes. So hyperdynamic circulation like exercise and fever will increase diffusion capacity, and very importantly, bronchial asthma. So in fact, bronchial asthma, particularly after an acute attack, will show you increase in the diffusion capacity. So even after the acute attacks of asthma is resolved, you can still find on to the next 2 weeks that the diffusion capacity still remains high. This is because there is a recruitment of blood in the alveolo-capillary blood. Muller's maneuver, which is again because you are inhaling against the closed glottis, there is more blood into the circulation, which will be able to pick up more carbon monoxide and hence will show you high diffusion capacity. So it's not Valsalva maneuver, it is Muller's maneuver which increases it. So we had given a choice of Valsalva maneuver. So actually Valsalva maneuver is exhalation against a closed glottis. So during which process actually it is the intrathoracic pressures are very high. So they are going to decrease the diffusion capacity, not increase the diffusion capacity. And cardiac causes, when there is shunting or congestive cardiac failure, all of them can also increase the diffusion capacity. Alveolar hemorrhage, everybody accepted. Obesity, I told you, we do not know exactly why, but it is because of the extra pulmonary factors that the diffusion capacity is more. High altitude because of the lower PI2, but then you correct it and it becomes okay. And of course, following bronchodilators. So if you give bronchodilator and then check the diffusion capacity, it increases 6%. So that's why I think in one of the modules, somebody has asked me, what is the sequence of tests? So the sequence of tests would be like spirometry, followed by body box lung volumes, and finally the diffusion capacity. And you do the bronchodilator test after that, and then you carry on with it. So otherwise, if you want to do a diffusion capacity after bronchodilator, you can do it, but in every opportunity, it has to be done the same way, because there is a significant difference, which is more than 5%, which occurs if you give a bronchodilator to a patient who's having obstructive airway disease, and of course, incorrect reference values. And that brings us to question number 12. Neeraj, over to you.
Yeah, so having been known causes of high DLCO, now we come to low DLCO. So what are the causes of low DLCO except pregnancy, emphysema, alveolar proteinosis, polycythemia, pulmonary embolism. Now I think it would be easier for
Easier, yes, Neeraj.
all
This
of
should
these.
be easy because we are talking about all these things, the things which are increasing because there is only one which actually increases the diffusion capacity. Rest of all of them are decreasing the diffusion capacity. And reason could be many.
75% they have polled for option D, polycythemia.
Very correct. So this is very easy because anemia, we do understand anemia decreases the diffusion capacity and polycythemia increases the diffusion capacity. So very
Others
correct.
have polled for pregnancy.
Some people have picked up pregnancy. Okay, so the decrease in diffusion capacity, this is very important for us to understand because I told you that it could be because of many things. One is that the area available for the diffusion is decreased, which could be because of pulmonary resection. It could be because of emphysema, and it could be because of VQ mismatch, where the air is primarily obstructed because of the bronchial obstruction and is not able to reach there at all. So the area available is not there. The one which is obstructed will not be participating in the diffusion process. So that is like cutting off the area. So emphysema, VQ, severe VQ mismatch, and due to bronchial obstruction as well as pulmonary resection are primarily affecting the area of the pulmonary membrane, alveolar membrane, which is being decreased and is available for the diffusion process. Entire alveolo-capillary membrane with the interstitium may be affected in diseases like ILDs, sarcoidosis, drug-induced ILDs. All across ILDs can affect this alveolo-capillary membrane. That's why I think everybody had picked up that DLCO is for alveolo-capillary membrane. It's not that, but this is an important aspect of it. Pulmonary vascular disease, which will again affect the alveolo-capillary membrane, like pulmonary hypertension or pulmonary embolism. Both of them will also affect it. And diffuse alveolar congestion, like late phase of pulmonary edema. Early pulmonary edema increases it. Late pulmonary edema decreases the diffusion capacity. Diffuse consolidation, pulmonary alveolar proteinosis, any filling process, whether it is consolidation, pneumonia, alveolar proteinosis, pulmonary edema, all of them will also decrease the diffusion capacity because the alveoli are not there. And then there's some miscellaneous causes like pregnancy. We do not know why, but 15% diffusion capacity falls during pregnancy. Valsalva manure, because primarily it decreases the amount of blood because intrathoracic pressure are high, then the blood flow is decreased. So there's less blood. So obviously the diffusion to the blood will be less and the diffusion capacity is going to be low. So Muller's manure increases it and Valsalva manure decreases the diffusion capacity. That's why you don't do these procedures during the performance of the test. If you do it, it will be giving a fallacious results. Extrapulmonary reduction, that is very important. Neuromuscular diseases, skeletal deformities like kyphoscoliosis. Lungs are healthy, but because the chest wall is bad, it doesn't allow the expansion to occur fully, doesn't allow the all air to get in, the alveoli to be ventilated well. So although the alveoli may be normal, the alveolo-capillary membrane may be normal, but still the diffusion capacity is going to be low because of the extrapulmonary causes, which are called, rather not extrapulmonary, they are called extrapulmonary extraparenchymal causes. That means the lung parenchyma is not affected, it is outside that. So whether it is even pleural effusion, chest wall deformities, everything will be bundled into extrapulmonary reduction in the primarily because the lung size is reduced there. Incorrect reference values and something other by, there is a, by alcohol, by the menstrual bleeding, and also by the diurnal variation of the diffusion capacity also exists. So that brings us to question number 13, and that is regarding the alveolar volume. So we had seen DLCO is equal to VA into KCO. So over to you, Neeraj.
So what is alveolar volume? It is calculated by carbon monoxide kinetics equal to TLC or TLC minus VA in severe COPD indicates trapped air or all of the above. So how do we define actually alveolar volume here?
I think this is again becomes very important because we discussed body box last time. Body box will determine all the air which is inside the chest and abdomen. We discussed last time, even the abdominal gas is included into it, which is about 150 ml or 100 to 120 ml or something like that, about 115 ml in the stomach. But there can be a gas outside the lung. It is in the lungs, but outside in a way that it is not communicating. So that all will be determined by TLC when we do it by total lung capacity by the body box. But by the helium dilution method, which is being used here, because we are using helium air to estimate the lung volume. So it is almost we are going to get even the total lung capacity or get an idea about the total lung capacity by looking at the VA in this situation. So that's why this question has come, that what you estimate as alveolar volume, is it like total lung capacity dependent, or it is dependent upon how well the lungs are being ventilated, or there is air trapped air there or not, or it is on carbon monoxide kinetics.
So one third for option 2, 1/3 for option 3, and 1/3 for option D.
Okay, so I think I would agree to a lot of you because this is a little confusing and a difficult question. But VA is not a total lung capacity. Remember that it can never be a total lung capacity, because when you do the procedure of DLCO, in which you breathe in from the RV to the TLC, if you are able to reach the TLC, it will be able to give it to you, the TLC. But most of the time it is not possible. We cannot reach up to the maximal total lung capacity in this procedure, because then it becomes a non-physiological test, and at that point of time the pressures are high, so it's difficult to reach and exactly at the TLC. So VA can never be equal to the TLC. That doesn't happen. But the difference between the VA what you get and the TLC you get from the body box, if it is huge, then obviously it tells you that there is a trap there. It could be a bulla even in those situations. So this concept of VA is actually, it is alveolar volume which is accessible. So accessible is very important, because you have a lot of air trapping in asthma and COPDs, obstructive airway disease, that cannot be assessed by VA. So it will underestimate the alveolar volume in such situations, because what we are going to do is we are going to check the air volume in the lungs, which is going to communicate, because it is going to be by the helium dilution method. So wherever the helium will go, it will be able to do it. Since you are doing it only for 10 seconds, it doesn't allow you a long time to equilibrate well. So you, if all those areas which are concealed or trapped air or bulla, or the areas which are not communicating with the airways, will not be able to participate in the helium dilution process and will not be picked up, and hence us underestimate the total lung capacity. So this is what we are talking about VA. It is always less than TLC, and in COPD it will be much less, because you are not giving time to equilibrate it well. But it is a rough estimate to tell you that if there is a lot of difference between VA and TLC, that there is a lot of inhomogeneity or poorly ventilated areas of the lung which are not in communication with the airways. So it's, if you look at the VA, which is normal, like it is supposed to be normal about 95%, above 90%, if you are able to achieve that, it is an indirect measure to tell you that most probably the total lung capacity is normal, and it is not a restrictive defect. So it can rule out a restrictive defect if VA is reaching above 90%. And 90, or even if it's reached 90 to 95%, means that the restrictive defect is not there. So many of the people don't perform the lung volumes. Actually, they will do only the diffusion capacity, look at the VA, and on a VA they will make an interpretation of whether the restriction is there or not. I hope all of you remember that total lung capacity is the one which is the determinant of restrictive defect. You cannot diagnose a restrictive defect unless and until the TLC is less than 80%. This is absolute. So if you have a TLC of 80% and above, the restrictive defect is ruled out. So on the same way, because the TLC is very close to VA, when VA has reached 90% and above, people will like to say that, okay, if VA is perfectly reaching about 90 to 95%, that means that we have almost no restriction or no restrictive defect in that individual patient. This is a rough guide, not an accurate guide. Another way of looking at is to correct the VA over the TLC ratio. So if you have a body box, you have done the lung volumes, you have TLC, then it can be incorporated in interpretation of the low diffusion capacity. So you can see this chart which tells us if you have a low VA over TLC ratio, which is, as I told you, it's supposed to be like above 80%, but preferably around 90. But if it is less than 80%, it is suggestive of obstruction. If you have this ratio, which is above 0.8 or 80%, it is indicative of restriction. So you can see that if you have a diffusion capacity low, you look at the VA. If VA is also low, try to look at VA over TLC. And if that is also low, then it is an obstructive disease. But if it is well preserved, it is a restrictive disease. And then you start interpreting with the use of KCO. So you can see that the entire interpretation of a diffusion capacity is not only around the DLCO or TLCO, but it is also dependent upon VA and finally at the KCO. So I think you people had all picked up very correctly that you don't only need the DLCO, but you need a VA and you need a KCO. And now I'm trying to interpret that TLC is also required. So TLC will come from the lung volumes. And as I told you, the most important and the best method to do is by the body box plethysmograph. Is the what is the normal KCO trying to tell you here? So if you look at it, that is it trying to tell us that it is consistent with intraparenchymal restriction with preserved KCO? What is the KCO means? So if the KCO is a normal, so a normal KCO should not be misinterpreted as indicative of no ILD. It's very important, because KCO low will mean that the VA is also low. So if DLCO is low, VA is low, then the ratio of the two is becoming normal, and that is the normal KCO. So normal KCO is not indicative of that there is no ILD. And it is a most common finding that you will find that the KCO is normal in patients who have got interstitial lung disease. So it can be there that the KCO may be normal when there is a loss of lung volume, like extremely fibrotic areas. There is no alveoli left. Honeycomb lungs are the ones which are most common thing in which there is no communication with the air. So although you have cysts, although you have these areas which are clearly seen, but they are extremely fibrotic.
Neeraj sir, please take it forward.
So it is hold up probably.
His internet gets down.
Am I audible?
Yes, sir.
So there is interruption in internet probably for Dr. Deepak. So these slides are also not visible.
Yes, disconnected by the way.
It is disconnected.
Please join again. Meanwhile, you can just take a few questions.
Okay, so we are back. Sorry. So I think, Neeraj, I had a little net issue at that point. So have we dealt with this question?
No. Actually, that screen was also not visible.
Okay, so this is a question talking about KCO. What is our knowledge about KCO? Over to you, Neeraj.
Yeah. So what we know about KCO, we have discussed KCO a lot in last slide. It is corrected DLCO for lung volume. It is efficiency of alveolar capillary membrane. A normal KCO means normal transfer factor or not routinely required in interpretation of diffusion study. So what do we mean?
The one answer is correct. So we have discussed about VA. Now we are discussing about KCO. That's the second component of the diffusion capacity. So we have seen about KCO that it can be normal in interstitial lung diseases also. So what is KCO after all? Why it happens normal in patients with an interstitial lung disease?
I think it is still not clear with quite a few of the audience.
Okay.
60% they have polled for option A, while 40% they have polled for option C.
Okay, so I think very correctly, because I knew that this is a little tough thing to understand, that we are trying to talk about, here that once we correct with VA, because DLCO divided by VA is equal to KCO. So that means if diffusion capacity is corrected for the volume, it will become KCO. But what is important to see here is that the kinetics are not straight. You can see that this is curvilinear. This is the most important thing. So that is why DLCO divided by VA, which is the KCO, is not a straight line. It is a curvilinear line. And that determines that this relationship is not linear. So that means 1 unit change in DLCO over VA will not produce 1 unit change in KCO. That is the difference. That is why it is not equivalent. It is primarily telling us about the kinetics, the rate of uptake of carbon monoxide from the alveoli at full lung inflation. That's what we are talking about. And it is corrected for the barometric pressure. So it has to be KCO divided by PB, which is equal there. So obviously there is a little difficulty in understanding, but what I'm trying to show you here is very clearly that you can see that alveolar volume and diffusion capacity, they have got a linear relationship. So as the volume increases, the diffusion capacity increases. As the volume decreases, the diffusion capacity decreases. But when it's corrected for the volume, it is not the same at each level. It is different. So unit by unit change does not occur, and it is curvilinear. So this is primarily trying to tell us when the volume changes, the kinetics also change. So even if you correct it for the VA, it doesn't become a straight line, and it is not an equivalent change. So that is why we need to understand that the KCO reflects the efficiency index of that membrane. It is not that we have just corrected it for the volume and now it is volume independent factor. It is volume independent factor, but it is trying to reflect the kinetics of the CO which is happening. So that is why it is called efficiency index. So KCO is trying to tell you that whatever membrane is there, what is the quality of that membrane? Whatever quality of whatever membrane has gone, that is decreased the diffusion capacity. But whatever membrane is left behind, it is if good, then the KCO will be either good or KCO will be bad, depending upon whatever is the KCO results we are getting. So KCO is not equivalent to what we are talking about, diffusion capacity corrected for the volume. Although it will look like in an equation, it is coming like that, but it has to be corrected for the barometric pressure. So it is a little difficult concept to understand, but I think if you remember this picture in mind, you'll remember the relationship is not linear. And that's a very important thing, that it will not be linear. So 1 unit change in VA does not lead to 1 unit change in DLCO across all possible VA values. So it is misleading ratio, and a normal KCO should not be used to rule out major pulmonary pathology. So sometimes, what it is trying to tell us is if KCO is normal, so that means the membrane is normal. It doesn't happen that way. You can have a pulmonary pathology even the VA is reduced, but KCO is preserved. We have seen that in extreme cases of pulmonary fibrosis, KCO may turn out to be normal completely, because it is trying to tell us about the efficiency of the uptake of whatever has been left behind. So normal, that brings to question number 15, and I hand over to Neeraj again.
Yes, I think this question and these kind of examples will be more explanatory for the audience. So cause of normal KCO with decreased DLCO. Is it emphysema or pulmonary fibrosis or a case of lobectomy or neuromuscular weakness? So what can be the causes of decreased DLCO with normal KCO?
So I think let's not confuse you. I have told you the normal KCO can be there in pulmonary fibrosis. It can be there in other diseases. But that is the extreme thing. Most probably when you look at a decreased diffusion capacity with normal KCO or high normal KCO, what do you start thinking of? That's the question. So let's see the answers, because this will require discussion. It will not be a simple question like this.
So 50% they have polled for neuromuscular weakness, 25% for lobectomy, and 25% for emphysema. And
I
none
think it's a very
polled
good
for pulmonary
answer.
fibrosis. None have polled for pulmonary fibrosis.
That's very good, actually. Although I have just in the previous slide explained everything that in pulmonary fibrosis it can happen, but that is obviously it can happen. That doesn't mean it's a usual phenomena. Only thing can happen means if you get it, it is still pulmonary fibrosis. Don't ignore that. But yes, neuromuscular weakness, everybody has put in the efforts there. That's very good answer, I suppose. It's a very good answer because this is also one of the correct answers which we are going to talk about. That as I told you, this is a transfer coefficient. KCO is a transfer coefficient, and it is basically determines whether the currently available alveolar spaces are functioning normally or not. And people have already said neuromuscular diseases because lungs are healthy, alveolar spaces are functioning normally, so you expect a normal KCO in them. So that's perfectly correct answer. So a low DLCO with the normal or a high KCO can be there in pneumonectomies also, and it can also be whenever the rest of the things are normal. But the DLCO can be falsely reduced in patients with severe COPD or ILD when the inspired carbon monoxide does not completely reach the functioning alveolar capillary unit. So we need to understand the DLCO can be falsely reduced. So the KCO is normal and the DCO is falsely reduced. So that's what we are talking about. And there are certain situations in which it is called pseudo-normal KCO. And that is in the restrictive defect, which I told you in patients with interstitial lung disease, it is falsely normal. And here it is very important to see that what is the VA-TLC ratio. As I told you that if it is less than 0.80 or 0.85, generally we take 0.80, then it is a restrictive defect. And that is what we are talking about, whether this restrictive defect is primarily because of the parenchymal disease like ILD or extra parenchymal disease like the diseases which we are talking about like neuromuscular diseases. So that brings us to question number 16. We have only 5 more questions left, and over to Neeraj.
Yeah. Now the another situation is low KCO with decreased DLCO. What can be these situations? Either fibrothorax, diaphragmatic palsy, poor cooperation, pulmonary vascular malformations, or all of the above. Low KCO with low DLCO.
So that means the efficiency of the membrane is also not good, which is contributing to decrease in the diffusion capacity.
So 50% they have polled for pulmonary vascular malformations and 50% for all of the above.
Okay, so 50-50 it goes. So, okay. So this is what we were talking about, low diffusion capacity with low KCO. It can be because of the diffuse alveolar destruction, because of the emphysema, or diffuse pulmonary fibrosis we have also discussed, which is called a pseudo situation, pulmonary hypertension, vasculitis, hepatopulmonary syndromes, pulmonary vascular malformations, and anemia. All of them could be the causes of low DLCO, low KCO. However, KCO can be high, particularly in neuromuscular diseases, chest wall diseases, pleural restrictions. So very important to remember that these are the conditions in which lungs are healthy. So the diffusion capacity is abnormally low because less air is getting in there because of the neuromuscular disorders, chest wall disorders, pleural restriction like fibrothorax, or there is a loss like pneumonectomy or atelectasis or consolidation. There could be technical reasons or even polycythemia or alveolar hemorrhage on the top of it, which is producing low diffusion capacity with a high KCO. So these are the situations which we need to keep in our mind. So when we generate a diffusion report, it is like unadjusted DLCO. Then we correct this DLCO for hemoglobin and if required for carboxyhemoglobin or PiO2 if you are doing it at a high altitude. Average VA, alveolar volume, that is available alveolar volume, and also KCO. So all these needs to be there when you look at the diffusion capacity report. And the stepwise interpretation of the diffusion report is first look at the DLCO. Is it reduced, or it is normal, or it is increased? And either it is associated with decrease in VA or KCO or not, because we know that the equation is DLCO is equal to VA into KCO. And very importantly, you need to see that whether your DLCO may be reduced because of hemoglobin or carboxyhemoglobin. So that corrections need to be done. So if you put it in the machine that the patient's hemoglobin is 9, then it will automatically correct and give you DLCO single breath corrected hemoglobin. So that will give you the value that this has been corrected for your current patient whose hemoglobin has been entered into the machine. Next, you look at the VA. It should be within 5% of the total lung capacity. And if not, then you have to think about it that why the patient could not achieve VA properly. And it can reduce the diffusion capacity. So it could be because of the loss of the lung volume, because of collapse, resection, neuromuscular diseases, embolic diseases, lots of them. And many a times it is because the patient has not done the procedure completely. So it can be a technical factor also. And then finally, you look at the KCO, whether the KCO is reduced, KCO is normal, or KCO is elevated. So it is also reduced in anemia, interstitial lung diseases, and pulmonary vascular diseases. And it is increased in extra pulmonary parenchymal causes like neuromuscular diseases, chest wall diseases, pleural diseases. We have all discussed about them. So we need to interpret into 3 different levels. So now these are the, the examples of various diseases, how they affect the KCO versus VA. Now all of them are causing decrease in diffusion capacity. TLCO percent is DLCO percent. So it is decreased in inspiratory muscle weakness. It is decreased in pneumonectomy. It is decreased in ILD. It is decreased in emphysema. And it is decreased in primary pulmonary hypertension. So you can see in all of them, it is less than 60% and it is reduced. But look at what is happening to KCO here. KCO is increased in inspiratory muscle weakness. It is also, generally we take 120 and 120 and above increased. 80 to 120 is considered as normal. So in pneumonectomy, despite the TLCO or the diffusion capacity being low, KCO is normal. In fibrosing interstitial lung disease, again, you can have a low diffusion capacity, but you also have a normal KCO. In emphysema, the diffusion capacity and KCO both are reduced. And in pulmonary hypertension, again, because it is the quality of the membrane uptake or the efficiency of the CO2 uptake by the membrane, both the KCO as well as the DLCO is reduced. Then what is the importance of VA? VA is trying to tell you whether the amount of air was adequate or not. Now in inspiratory muscle weakness, you can't inhale completely. VA is going to be reduced. So you can see that it is 48%. In pneumonectomy, again, there is, because part of the lung has been removed, so the less air will go, 50% will go. VA is going to be reduced 50%. Interstitial lung diseases, total lung capacity is reduced, VA will be reduced. So it is showing 66%. And if you look at emphysema, obviously there is more. So 91%. So VA is increased in emphysema and also in pulmonary hypertension. So total lung capacity is normal in pulmonary hypertension. So VA is also going to be normal or increased there. So emphysema and pulmonary hypertension, VA is increased. Rest all conditions, VA is decreased. And KCO is increased only in the extra pulmonary parenchymal factors like inspiratory muscle weakness, chest wall, or pleural diseases. It can be falsely normal or pseudo-normal in fibrosing alveolitis also. So grading is, as I told you, normal about 80 to 100%. And above 120% is abnormal. And then you have 80, 60, 40, 20 rule. Less than 20 is very severe, 20 to 40 is severe, and then moderate is 40 to 60, 59, and then 60 to 80, and 80 to 100. This is the severity. Severity is important with the survival of the patients. And that brings us to the last 4 questions, which are based on the case studies. So this is the case study. You can see that we have given you the spirometry, we have given you the lung volumes, and we have given you the diffusion capacity. So I think, Neeraj, you can go through the study with them so that they are able to pick up the choices.
Yeah. So what we have to look for, number 1, whether it is a obstructive disorder or a restrictive disorder with spirometric parameters. Then also have a look on RV-TLC ratio, and of course in the last, the diffusion. So what do you think? On FEC, it is almost 71%. FeV1 79%, and the ratio is 116%. Then have a look at RVTLC. It is 132%. That is, and diffusion capacity, that is 68%, and KCO is 65%. So KCO is in the normal limits, diffusion a little bit low with probably restrictive disorder. So what do you think? It is a normal spirometry,
Like,
or there is a bronchial asthma, or there is obstructive disorder, or there is a restrictive disorder?
so are we seeing the choices here? Because the choices are, I think,
They are given on the
different.
top.
So are the choices given same one, normal, bronchial asthma, ILD, and bronchiectasis, or the
Yes.
choices are something else?
Yeah, these are the four choices: normal,
Okay,
bronchial, and bronchial.
okay. I think almost Neeraj has handheld the entire audience through the interpretation of this report of spirometry, lung volumes, diffusion capacity. Only thing what is missing here is actually the VA, which should have been there. And if you can see DLCO, small c single breath is written. Small c means corrected. So that means it is corrected for the hemoglobin.
Yes.
So anemia is not the reason here.
So 67% they have polled for option 2, that is bronchial asthma. And 22% they have polled for option 3, that is interstitial lung disease, and 11% for option 1, that is normal.
And nobody picked up bronchiectasis here.
Nobody picked the bronchitis.
Okay. So now we are talking about, I think the Neeraj had given a first hint that the ratio is normal. So normal ratio rules out obstructive airway disease. Then you come to the second thing, TLC, 84%. TLC above 80% rules out restrictive defect. So we are not getting anything clear on spirometry for obstruction and restriction from the lung volumes. Only thing what we are getting is that the diffusion capacity is low, and KCO, which is the efficiency index of the alveolo-capillary membrane, which is normal. So this is a very complex kind of a situation. It is not a clear-cut simple case. It could be normal also. There is no doubt about it. And this is the algorithm which I discussed last time also, that I will show you, that you start with the ratio. Now the ratio you have reached here, normal. Look at the FVC, 71%. It is low. Look at the TLC. TLC is coming to normal. So you have reached the TLC, which is our normal here. Now in the normal TLC, you can have only the obstructive defect there. You look at the diffusion capacity. Diffusion capacity is low. You are here. And then you look at the KCO. KCO is normal. And actually you reach the diagnosis of bronchiectasis. You need to do the CT scan of this patient to look at the bronchiectasis. This is the flow chart algorithm by ERS. And you can see that it may be very, very near there. But this kind of situations are very, very difficult, where there's a lot of confusion, because sometimes they are complex disorders. So there may be balancing effect on the TLC. There is a disease which is trying to increase, which is obstruction, and there's a disease which is trying to decrease the TLC, and both of them balancing each other so that the total lung capacity is normal. So these are called mimics, where you need to pick up the things very closely, and bronchiectasis is very difficult because it has both restriction as well as obstruction. And I think Dr. Neeraj had given you a very good clue here, that the RV-TLC ratio was actually coming out to be a little higher, 132%, which is more than 130%, which is generally considered as normal. So it was telling you that there is something else going on. Although there is no obstruction we can see, but there is something else which is going on. And then with a decrease in diffusion capacity and normal KCO, you are into a situation where it's more of a mixed thing, which is one disease, one kind of a defect trying to overlap with the other one, which is very common in bronchiectasis, because bronchiectasis and sarcoidosis are two conditions which can have both mixed defects, the obstructive as well as restrictive from the complete lung function test gametes, which like we have done here. So we can consider that there. So we move on to study number 2. And I think again, I will hand it to Neeraj to help you out in this case also. And he did it very well in the last time. And I'm sure that you listen to him where he is trying to focus your attention, because there are lots of values. And when you are watching this on your mobile phones, this is very small place to see all these things. But I'm sure Dr. Neeraj will help you out. Over to you, Neeraj.
Yeah. So have a look at first spirometric parameters, FVC, FEV1 and FEV1 FVC ratio. %50 for FVC pre, 47% FEV1 and FEV1 FVC ratio 97%. Peak expiratory flow is normal. So we can expect a restrictive disorder here. You can also have a look at the graph which is given. So we can expect a restrictive disorder. But if we look at the reversibility post bronchodilator, it is the 12% change in FEV1, but it does not meet the criteria of 200 ml, only 170 ml increase in FEV1 and 12% change. So either it is a restrictive disorder or there may be a mixed type of disorder, that is restriction plus some component of obstruction. Then have a look at DLCO, which is 73%, KCO is 138%, more than 100%. Again, also have a look at RV-TLC and RV-TLC ratio, which is 159%. So this is for sure that there is some air trapping. 159% means there is some air trapping in the lungs with probably a mixed type of ventilated disorder with a normal DLCO and increased KCO. Dr. Deepak, please.
I know, but this, you have wonderfully explained the whole thing. So people have voted for this?
Yeah, I'll just see. I'll just have a look on it. Yeah, they have voted for option 2, 41%, option 3, 28%, and option 4, 31%.
Okay. So I think Neeraj had made you very clear that, this is a restrictive defect. There is no doubt about it. The only thing is, along with restriction, is there any obstructive defect or not? And he again showed you, because see, TLC 66%. That means restriction is there. There is no doubt about it. Never confuse all these things when first look at the TLC. If TLC is low, restriction is there. Now on the top of restriction, whether it is a mixed defect with obstruction or not, you start looking for other things. You have seen FEV1 over FVC ratio, which is coming to 72.84 absolute terms. You look at the reversibility, which is like borderline, not doing good. RV-TLC ratio, which is 159%, very high. So now you are looking at a kind of a mixed defect. Now, when you look at the diffusion capacity, 73%, which is DLCO reduced, and the KCO is markedly elevated. So markedly elevated KLCO will give you some areas of thinking where the restrictive defects are. So if this kind of a situation is entirely coming up into such situations, again, if we try to put into this, you can see the same chart. You can see that the FVC is reduced. FEV1 over FVC ratio, you can take either low or normal, whatever you want to take, but ultimately you come to TLC, which is low. So if you go by this restrictive defect, but if the ratio and RV-TLC ratio is giving an obstructive also, you reach here, mixed obstructive and restrictive defect. That's what you are reaching here. So if this patient is obese and asthmatic, this is perfect picture which we are getting here. Obesity is causing and asthma is causing increase in KCO in this patient. KCO is increased because of obesity, partial reversibility, pseudo restriction primarily because of obesity. And this is like kind of mixed pictures and confusing pictures which you get, where you need to do a complete spectrum of tests, not only spirometry before and after bronchodilators, lung volumes, complete body box lung volumes, and a complete diffusion capacity. And sometimes there may be more than one restriction causing it. It could be underlying interstitial lung disease with partial reversibility. Like sometimes you get it in hypersensitivity pneumonitis or sarcoidosis, diseases like that. And in them, then there is a diffusion capacity which is reduced, but again the KCO is increased. So it could be because of the neuromuscular weakness. So a patient who's a sarcoidosis and the patient who's on steroids with muscular weakness, again, this is compatible with that. So you need to interpret your lung functions along to the clinical parameters of the patient or the clinical history of the patient. That is very important. That we move on to the case study number 3. We have 5 cases, so we have 2 more cases left. And quickly to Dr. Neeraj.
So have a look at spirometric parameter and the graph which is given. You have also been given an option of VA TLCO, that is 0.89. So FVC is 74%, FEV1 61%, with FEV1 FVC ratio of 87%. So what do you think? Is obstruction, restriction, or normal? Then have a look at residual volume. RV, it is 57%. Then have a look at diffusion capacity, that is 68%. KCO is 111%. Single breath alveolar volume is 63%.
So in this one, we have given a lot more data actually.
Yeah.
Of the diffusion study. We have given almost the entire data. You can see the diffusion study.
Of the TLC 0.89. And the options are COPD, ILD, PAH, or neuromuscular weakness. Let us see what are the responses here. So 50% they have polled for neuromuscular weakness, 33% for pulmonary arterial hypertension, and 17% for ILD. None have voted for COPD.
So at least we are happy that obstruction has been thrown out. We are only left with somewhere around a restrictive defect. Everybody picked up that TLC is 69%, means restriction is there. There is no doubt about it. And when you are given the choices, COPD gets out there unless and until it is associated with the underlying disease which is causing restriction. And we have 3 choices here: ILD, PAH, as well as a neuromuscular weakness. Remember that we discussed, that the KCO can be normal but not high in ILD and also in pulmonary hypertension. So neuromuscular weakness is something which you need to consider here. But yes, in sometimes, as I've discussed with you, that ILD can be there. And here, very importantly, you look at the VA. VA is coming 63%. It is also reduced in parallel to TLC, which is 69%. So that's the reason why the VA is less here. Breath holding time is 10.43 seconds. So you need 10 seconds. So that is good enough. So you can see that we have been able to get the test performed well. Diffusion capacity, DLCO single breath corrected is 68%, which is low. KCO is raised. So you need to explain an restrictive defect here, which has got increased in KCO with decrease in DLCO. I think I had shown you this in the previous slide, where what are the conditions where you get a decreased DLCO with a normal or high KCO. So neuromuscular diseases, pneumonectomy, pleural restrictions, all of this will come into this kind of a scenario which we are talking about. And I think it was case study 3. Okay. So again, as I told you, VA over TLCO ratio becomes very important. And here it is given as 2.89, which is normal. So it is a restrictive defect. There is no doubt we have reached here. But KCO, if KCO is increased, it is extra parenchymal. So you have to think about a neuromuscular disease. So everybody who picked up neuromuscular disease is correct, because this is the flow chart. You can clearly see here that you reach, whether you go by this chart or you go by the ERS ETS guideline chart, you will be able to see the same. The TLC is low. It goes into restriction. Then the diffusion capacity, which is low, and then KCO, which is high or normal. So the mixed loss, again, it is coming out to be here. So there can be an additional restriction. Some of you would have picked it up as ILD or PH. PH is unlikely, but ILD may be there, but underlying neuromuscular weakness becomes a very important one here. So with that, we move on to case number 4, and over to you, Neeraj.
Yes, so we do have spirometric parameters here, and we do have DLCO and KCO. TLC, RV, TLC ratios are normal. It has been mentioned separately. So let us have a look at spirometric parameters. FVC 85%, FEV1 80%, FEV1 FVC ratio is 97%. So it seems to be a normal spirometry looking at these parameters, although we don't have a graph here to confirm. Then our TLC, RV, TLC ratio, they are normal. But DLCO is reduced 53% and KCO is also reduced 73%. So what can be the...
This is a very...
Yeah. So what can be the possibility, whether it is a neuromuscular weakness, a normal person, ILD, interstitial lung disease, or pulmonary arterial hypertension? I think it is a little bit easy to interpret.
Easy. Okay, good.
It should be easy.
I think the way you have come across, I think, Neeraj, by ruling out obstruction and then coming to the TLC, RV ratios also normal, and coming to where the diffusion and KCO both are reduced.
So we have got 42% they have responded for option 4, pulmonary arterial hypertension. 33% for option 2, that is normal, and 25% for option 3, that is interstitial lung disease.
Okay, so this is a kind of situation which is called isolated decrease in diffusion capacity, DLCO. And obviously you are looking at KCO here, whether the KCO is normal, supernormal, or it is low, and we find it low here. So such a kind of situation can occur in lot of diseases. Many of the times when you do lung function test, you find spirometry normal, lung volumes normal, and only isolated reduced diffusion capacity. And there is a study which tried to look into so many PFTs, I think more than 5,000 PFTs, and they found only 0.5% do have such kind of finding, which is isolated reduced diffusion capacity. And they did a complete analysis of these patients, and they found almost 50% had emphysema on the CT scan. And since it was like everything coming out to be normal, 85% had concomitant interstitial lung disease. So combined ILD with emphysema is the most common cause where you're trying to balance out each other. So that's a possibility. They also find a pulmonary vascular disease in 7%, and almost about 19 to 20% there was no cause. So that means it was a normal variation. So the various causes are pulmonary vascular disease, pulmonary hypertension, congestive cardiac failure, anemia. But in this case, we had corrected for the hemoglobin, so anemia was out. Early emphysema is a possibility where the lung volumes are normal and there is no reduction in FEV1 over FVC ratio. Airway resistance of the body box, if what was done along with it, if it shows raised, you will pick up the choice of early emphysema. So that's the importance of doing lung volumes by body box. You will be getting airway resistance. If it is 150% total airway resistance or the effective airway resistance, you know that this is a patient who's got underlying obstructive airway disease with normal lung volumes, with no decrease in FEV1 over FVC ratio, only reduced diffusion capacity. We are looking at emphysema. So that's how we diagnose. Morbid obesity. Yes, in those conditions, generally the difficulty is that the ratio, what we are talking about, KCO, is elevated. So in this, the KCO is reduced. Cirrhosis of liver, diabetic lungs, kyphosis, and eventration of diaphragms all have been associated with isolated reduced diffusion capacity. So when you get this kind of a finding in a complete lung function test, which includes lung volumes and diffusion capacity, you need to evaluate one by one that which is the most likely. And most likely missed is pulmonary vascular disease or combined emphysema and interstitial lung disease, that is CPFE, for which you require an HRCT. If HRCT is normal and you get this isolated reduced diffusion capacity, most likely what you are looking at is a pulmonary vascular disease, that is pulmonary hypertension. And that brings us to the last case, which is the case in which I think we are showing you the spirometry lung volumes. And so you can take it Sorry. What happened? So yeah, you can, Neeraj, you can take this. I think
What is the cause of shortness of breath in this patient? We have got spirometric parameters, 65% FVC, 65% FEV1, 102% FEV1 FVC ratio. You can have a look on the graph which is available here. I think it is typically showing a restrictive pattern. Then RV TLC is reduced 71%. RV TLC ratio is 117%. And of course, we do have VA TLC here 0.82. So
which again shows. So what would be the choice actually? I think we have given 4 choices here.
yes.
So the last study was more like pulmonary hypertension. Let's see what this one comes out. You have a clear guidance given on spirometry and lung volumes by Dr. Neeraj. He has already explained you, and he has also given you a VA TLC ratio. I do not know, the diffusion capacity is not coming here, but once I think we'll have the results, we'll be able to see that.
So 33% they have polled for COPD, option 2, 50% for option 3, and 17% for option 4.
So I think I'm not able to show the diffusion capacity. So what I'm going to do is I'm going to share the screen again in a short so that we can see the diffusion capacity. So I think people can see the diffusion capacity now.
Yes.
So what have people polled in here?
So diffusion here is 76%. And breathe hold time is good enough, 10.9. KCO is 130%, 32%, that is super normal. VA 59%. DLCO corrected is 76%. Okay, KCO is 132. So there is super normal KCO with slightly reduced DLCO, restrictive ventilatory disorder, and RVTLC a little bit more.
And we have 4 choices given, and yes. I think you have practically ruled out one by one a lot of them here. So what are the choices people have polled, or people will poll now? Support team, can we have the question now? Support team?
Yes, sir, already polled.
Already polled. So just show the answers to Dr. Neeraj. So let's see what are the answers.
So they have polled 63%, they have polled for option 3, that is ILD. 20% they have polled for option 2, that is COPD. And 10% for option 1. 63, so majority they go with ILD.
So I think, Neeraj, the reason was that the diffusion capacity they hadn't seen before voting. Is that right?
Maybe. It may be there.
That is the reason. I think the polling has gone wrong because of that. I think people will say that to me later on by the messages that they are not seeing the diffusion capacity. Obviously, if you look at the first amount of parameters, the normal VA TLC ratio, actually what was given, it rules out an obstructive disease. So COPD is out. So the choices are between neuromuscular weakness, ILD, and pulmonary arterial hypertension. Now, the only clue which comes out is from DLCO and KCO. Increased KCO will not occur in ILD, it will not occur in PH, and it will only occur in neuromuscular weakness. So in fact, if you look at this kind of a study, you really understand that this is primarily a neuromuscular disorder, and you need to do the test more. And actually you are showing these results. You have the pressures, the peak, this inspiratory pressure and expiratory pressures all were low in this patient. And then we did the spirometry in supine and a sitting position, and you can see that nearly 40% fall in FVC on lying down, which confirms the diagnosis of actually the diaphragmatic palsy. So this is how you have reached the tree of diagnosis of diaphragmatic palsy or diaphragmatic weakness, whatever you want to call. In this patient, it was a diaphragmatic palsy completely, and neuromuscular disease. primarily because the KCO was raised, everything with a restrictive effect, but KCO raised. Remember, the KCO is the efficiency, basically, of the transfer of gas from the air into the blood. It is the efficiency, the quality of your membrane. So that means the quality of membrane is good. So the quality of membrane will be good when it is interstitial lung disease? No. It will happen when it is a pulmonary hypertension? No. It will happen when there are disorders outside the lungs. So neuromuscular weakness, like either the chest wall disorder or a diaphragmatic weakness, would have been the causes which needs to be looked up in such situations. So with this, we have come to an end. So if there are any questions, Dr. Neeraj will be taking with me. Thank you very much.
So just a minute.
It was a marathon 2-hour run for a diffusion study, I think.
Yeah. But it was very interesting, quite informative. And probably all of us, we have learned a lot. Just a minute for questions. So there are more than 100 questions.
We need to have one seminar for questions only. Q&A.
We'll take a few of these
Few
questions.
of them.
Yeah. So one of the question is, does long-standing type 2 diabetes, microvascular complications affecting lung vascular, affects diffusion capacity?
This is a very good question, actually. I think, the microvasculature in the lung reflects of whatever is happening at the microvasculature level in the entire body in long-standing diabetes mellitus. So you have eye changes, you have kidney changes, and you have alveolo-capillary membrane changes. So you have microangiopathy in the pulmonary circulation, the pulmonary capillary circulation, which is reflected in the form of decrease in diffusion capacity in the patients. So as I said, that isolated decreased diffusion capacity without affecting the lung volumes and spirometry is one of the findings of long-standing diabetes mellitus. So this is actually one of the things which are being now talked about diabetic lung.
So another question by Dr. Radha Munja is, in asthma, TLCO may increase, in COPD, it is decreased. So can we use this test after spirometry to confirm diagnosis or in patients with ACO?
I think, Dr. Radha, you have very rightly said that, in bronchial asthma, the diffusion capacity is increased. And when we talk about COPD, it will be either normal or decreased. But the caveat here is that in bronchial asthma, the DLCO is increased only after an acute attack or immediately after an acute attack. Over a period of time, like 2 weeks onwards, the diffusion capacity becomes normal. So like if you have a patient with acute exacerbation and you treat, and at the time of discharge, you find that the diffusion capacity is 120%, then it is predominant asthma. Definitely in that echo situation, you can infer that. It's a very wonderful, good question. And it is of very good help to us at the time of discharge after acute exacerbation, because most of them will bundle together like either COPD exacerbation or echo exacerbation, but you do not know whether the asthma component is more or not. But definitely an increase in diffusion capacity is indicated that it is not more COPD, it is more towards asthma.
Another question from Dr. Lovely from Delhi. How will be the DLCO affected in cystic lung disease?
Okay, so as I discussed, bronchiectasis is the most important cystic lung disease which we are talking about. And in bronchiectasis, it is primarily a reduced diffusion capacity as well as a reduced KCO also, because the membrane quality is also bad. So the index, what we are talking about, KCO is bad, then also the DLCO is bad. And since the cystic lung diseases also decreases the total lung capacity depending upon how extensive is the disease, so it will have a mixed defect, obstructive defect, restrictive defect, and the diffusion capacity will be primarily determined by the cystic component. So invariably the DLCO is reduced because of the cystic component rather than the obstructive disease. So you can have a mixed pattern of obstruction and restriction on spirometry and lung volumes. However, the diffusion capacity is going to be reduced, and the KCO is also going to be reduced in this situation.
So another question, I think it is a technical one. How easy or difficult it is to procure a standardized gas combination cylinder for DLCO test?
So I think it is a very relevant question for those who are using it in the laboratories, because the cylinders which are provided by the companies are very expensive. And if you ask the industrial filled cylinders which are also available in the market, they are very, very cheap. So the price difference between the two is almost about 6 to 10 times. So that gets reflected on the cost of the test. But the problem is the industry filled cylinders, which are like locally the industry will fill it. Those do not have accurate concentrations of CO, helium, and what we are talking about is oxygen. So if that is not there, then the entire estimation of whether you are doing lung volumes by helium dilution or you are using diffusion capacity by that, it is not going to be useful. So we need to buy the standardized gas cylinders from the people who have given us the equipment. That's a limiting factor for it.
Another question is, what is the role of calibration before doing test?
That's again very important. We discussed last time, like, for the body box, the calibration is done every day in the morning. For a spirometer, you may do once a week. That is good enough. Obviously, it depends upon the load in the laboratory. For a diffusion capacity test, again, the calibration is very important. And we need to calibrate the machine, but we don't do it again daily. For a diffusion study, we do it again once a week. Calibration is done. And it is basically to look at the VA. So if VA and the analyzers are not correct, so that is how it is not correct. So what we need to use is the same gas and analyze it and look at the calibration standards also. So we do it once a week for the diffusion study.
Now, does some of the patients, they are on long-term oxygen therapy or on domiciliary oxygen therapy, does it affect the DLCO test?
Okay. So you need to discontinue the diffusion, discontinue their oxygen for performing the diffusion test. So that's the limitation factor, because you cannot allow them to be on oxygen to perform the test. So to do the diffusion capacity test, so if the saturation is going below 85%, so you cannot perform it. But if it is borderline, you can do it. There are some people who try to use it, the intra-breath test, in which you just don't need the breath hold and other things. But some of the machines are provided with the intra-breath along with the single breath. Both of them can be done in the same machine.
Another question, what is the normal reference range for KCO?
So since KCO is primarily looking at, the normal value of KCO is about 4 to 5 ml. So that's what we are looking at basically in this situation. So it is because corrected factor. So once you look at the corrected factors, so we have the predicteds, like if you can see the reports, it is given there, but most of the times we are just trying to compare the values with the previous values.
So last question, I think it has been discussed, but I will like to repeat. How much time should be given for repeat DLCO trials? Is it more than 10 minutes?
How much time we need to give for?
Repeat DLCO trials.
Repeat DLCO, yes. So as I said, 4 minutes is recommended. So generally we wait for about 5 minutes before each test, not more than 5 tests, 5 times to be attempted at each session. And very important is to see the back pressure of COHB does not occur. So obviously, if patient is a smoker, you need to give more time and less number of procedures.
So these are all about some important questions. So
thank you, Neeraj.
I also thank you very much, Dr. Deepak. Again, I will like to have a quote by Mr. Benjamin Franklin. Tell me and I forget. Teach me and I remember. Involve me and I learn. So this is what we have experienced. You have involved all the audience and they have learned a lot from this session. And probably this series will provide a roadmap for interpretation of advanced pulmonary function test and evaluation of breathlessness.
So there are certain people, Neeraj, there are certain people who have been asking me that how can they archive this program later on. So I have no idea. So I think if you can throw a light, or maybe there is some other way of doing it so that they know about it, how to archive it. So I have no idea.
So I think link is available, and what we could have done is we could have some live or recorded manure doing DLCO testing or body box, so that a 5 minutes recording version would have been more informative along with all these slides. So we can include these, I think, in next 2 of our webinars for CPET. Have a 2 or 3 minutes or 5 minutes recording so that the people are well versed with the procedure also.
Right. I think that's a very good idea, and we'll incorporate it. So thank you very much, Neeraj, and thank you for the organizers. Thank you for the ICS and PACS under which we have done this program. And next 2 Wednesdays, we are going to talk about series 3 and 4, which is on cardiopulmonary exercise testing. We are going to start with basics and then go for the advanced one. Thank you, Neeraj. Thank you, everyone.
Welcome.
Thank you. Thank you, everyone.